Yeah. We are going to talk today about the relationship between pregnancy and biliary and pancreatic disease. This is an old problem, so I need a background that is starting in the 70s of the last century. If you have a look at these old epidemiological studies, no. Yes, it's not very strong. Okay, you see these four studies. McClure, that published on New England Journal of Medicine, a paper about NARS cohort, he failed to find any relationship between parity and the presence of gallstones. But in two epidemiological studies carried out in Italy, one from Professor Barbara that studied the population of Sirmione, a small village in the Garda Lake, and Professor Capocaccia and Professor Attili in Rome with the GREPCO, they both found a relationship between parity and gallstones disease. But they also found that there was some trend because parity seems to be related to gallstones only for young women. And the same things was found by Dr. Scragg that published on British Medical Journal in the same years a case control study from Australia in which, again, he found that parity was a risk factor for stones, but only if the pregnancies were in young women. So, have a look at the pathophysiology of what happened in the bile and in the motility of the gallbladder during pregnancy. Just a look at the old triangle. Maybe most of you are gynecologists, so this is less familiar with you, but it's much more familiar for gastroenterologists. In this triangle, you see that each side is representative of the phospholipids, bile acids, and cholesterol. Increasing and decreasing, you have more chance or less chance to have stones, and only in the bottom on the left, where there is the gray zone, here there is the concentration of the three components of the bile that may help to precipitate crystals and then stones. In this famous study of the Journal of Clinical Investigation of Dr. Kern, they investigated the gallbladder bile of women submitted to estrogen therapy and found that cholesterol was significantly increased inside the bile, like lipogenic index. But if we look at phospholipids and bile acids, you see that phospholipids and bile acids are not influenced by estrogen, and only cholesterol increases with the estrogen therapy, including pregnancy. So the increase in cholesterol without an increase in bile acids and phospholipids helps in the formation of stones and biliary sludge. So about the motility. About the motility, the same group by Dr. Kern looked at the fasting residual volume of the bladder in starting pregnancy and in late pregnancy. And you see that when you are in the last trimester of pregnancy, you have less motility and more volume. And the same is quite clear if you compare the last weeks of pregnancy in the plotted line with the control, that is the continued line, and you see that the motility of the gallbladder is less than half for the late pregnancy. So you have that during pregnancy, estrogen mainly in the last trimester of pregnancy increase cholesterol and liptogenicity index, while increased progesterone increase in all the pregnancy, decreasing of the pregnancy, the motility of the gallbladder. A gallbladder without motility, with an high lithogenic index, is, of course, at risk for precipitation of crystals, biliary sludge, and stones. But this is in laboratory. Look at what happened in the women. In this paper that I published on Journal of Pathology in 1987, we have a look to 300 women that had delivery just a couple of days before they were visited, submitted to ultrasonography, and they answered some questions about their clinical problems. We found in 80 of these 300 women the presence of biliary sludge. This is the first time in the literature in which there is the evidence of biliary sludge in so many women during pregnancy. Later defined as being confirmed some other authors, maybe in less percent of women, probably because we tried to look at the biliary sludge not only when the patient was just standing, but also when he moved from the left and the right side to obtain a movement of the biliary sludge inside the gallbladder. And also we found stones in 16 patients. Stones, of course, were of different size, but 6 very, very small, about 12 centimeters or less. 4 were between half and 1 centimeters, the others were larger. We looked also at the risk factor for stones, and we confirmed that increasing age was a risk factor for stones, that the use of oral contraceptive was a risk factor for the presence of stones. Obesity was a risk factor for stones. We failed to confirm that parity was a risk factor for stones. But we then followed up all the women that had a pathological gallbladder for 1 year. And we found that more than 30% and about 95% of biliary sludge spontaneously disappear at the end of the year of follow-up, 4 months at the end of the year of follow-up. But also we had that 2 out of 16 patients with stones had an empty gallbladder at the end of the year after delivery. And again, this is the first time in which there is a spontaneous disappearance of stones in a physiological group of patients. To the light of these results, we started a new study recruiting about 2,075 women at the first trimester of pregnancy. The paper was published on Annals of Internal Medicine in 1987. The patients were seen by ultrasound and clinical interview at the end of the first trimester, at the end of the second trimester, and 1 or 2 weeks after delivery, and then again for 1 year if they have a gallbladder disease. And we found at the first presentation, so at the end of the first trimester, that the incidence of the presence, so the prevalence of sludge was in 14%, and 2% was for the presence of ghosts. And from the first trimester to the end of the pregnancy, so in the control after delivery, we observed an incidence of new sludge of 34% and the incidence of new stones in 1%. So mean that we had 16 patients with stones at the first control in the first trimester, and 23 at the end of the pregnancy. Also, we looked at the predictors, and we obtained that obesity was a risk factor for the presence of biliary sludge, but we had only 6 new stones during the follow-up, and so we have not enough statistical power for showing a risk factor for appearance of new stones. But anyway, the presence of biliary sludge in the first presentation at the end of the first trimester was a risk factor for new stones. And what about symptoms? Symptoms was just colic, biliary colic. We had 8 biliary colic in the stones patients during the pregnancy. So 8 colics out of 23 patients, and 5 biliary colic in the year of the follow-up, and 3 patients during and after pregnancy with biliary sludge and also biliary colic. What about the disappearance? The spontaneous disappearance. So we look at the disappearance of biliary sludge and biliary stones, and after 1 year, we had that biliary sludge disappear in more than 70% of the patients, but in 30% of the biliary stones patients had a spontaneous disappearance. 7 out of 23 patients had an empty gallbladder at the end of the follow-up. And we observed the predictors of spontaneous disappearance of stones because we didn't find any predictor for biliary sludge. And the predictors for the spontaneous disappearance of the stones were a small size of the stones, because stones, the mean diameter of the stones that spontaneously disappear was about 0.5 centimeters, while the medium size of the stones that didn't disappear was 11 millimeters. And it was not surprising. But what was really surprising is that the stones spontaneously disappear only in older new mothers. So, like we have seen in the epidemiological studies that parity seems to be related to the stones in young mothers, stones spontaneously disappear in older mothers. But acute pancreatitis and pregnancy have biliary sludge and stones in common, because biliary sludge and stones are in the etiology of acute pancreatitis, and biliary sludge and stones have an impressive incidence during pregnancy. And when I started doing study about that was at the end of the last century, when I was working with Gino Di Magno in Rochester at the Mayo Clinic, there were only case reports in some hospital series about acute pancreatitis and pregnancy. So we conducted a case control study in the population of the Olmsted County, and we obtained 61 women in childbearing age with acute pancreatitis in 20 years of follow-up at the Olmsted County. We chose 4 control for each case. Then we look at the presence of pregnancy in the patients with pancreatitis and controls without pancreatitis. If we look at the prevalence in all the series of 61 acute pancreatitis, we see that the prevalence was about 12%. That was not significantly different from the control group. But if we look at gallstones pancreatitis, in the gallstones pancreatitis, the prevalence of pregnancy was of 30%, something more, and yes, 31 point, and was significantly higher respect to the 12% of prevalence in the control that didn't change. So, in our conclusion, and all the women with acute pancreatitis had pancreatitis only in the year after delivery. So the conclusion was that pregnancy is not related to acute pancreatitis. Gallstones pancreatitis is more frequent in the postpartum, only when gallstones is the etiology of the pancreatitis. But when we look at the cohort of the acute pancreatitis, we have seen that the pancreatitis was more frequent with a relative risk of 14 in youngest new mothers. So again, we have that age is important in relationship with gallbladder and acute pancreatitis gallstones related in women that are new mothers. The paper was published on Mayo Clinic Proceedings. After 20 years, because the paper of the Mayo Clinic Proceedings was in the first year of the century, of the new century, a couple of years ago, I restarted with my research on the item. And I have taken the population of the Sicilian population, so all the childbearing age women that live in Sicily, and I have seen for 6 years all the population looking for the presence of pregnancy, delivery, and acute pancreatitis. We studied with hospital discharge records, and we obtained 7.5 million women year of observation, and in non-pregnancy, and we had also 1,800 acute pancreatitis. And in non-pregnancy, the pancreatitis were 1,500 and something more, with an incidence of 20 for 100,000 women year. During pregnancy, we had only 34 acute pancreatitis during pregnancy. The incidence was 20 for 100,000. Of course, there was no difference between pregnant and non-pregnant women. But we also have a look at the incidence in the different trimesters. So we had that the first trimester, the incidence was 28. In the second trimester was 17. In the last trimester was 14. This is very curious because in the last trimester, we have the most of biliary sludge and stones respect to the first trimester. But we have more sludge and more stones, the pregnancy is going up, less acute pancreatitis. Look, these differences are not significant, but we have only 34 acute pancreatitis. So, of course, we have no statistical power to show difference, but the trend is clear. Let's go to see what happened in the postpartum. In the first semester after delivery, the incidence of acute pancreatitis became 95 for 100,000. That is impressive because it is 4 times the controls. It's 7 times the last trimester of pregnancy. And this increase in incidence continue in the second semester with 40 to 100,000. In the second year, that is more than 35 and so on. But in the third year, the difference is not different from the controls. So we have that acute pancreatitis is much more incident in the first semester, is more frequent in the 2 years after delivery. And if we look at the age, because age is important, as you remember, in the light blue column, you have the controls in which the incidence is increasing with age, because every colon is an age different, from the youngest on the left to the oldest on the right. But if you look at the red column that are the postpartum acute pancreatitis, you see the contrary. The top of the incidence is in the youngest, and they are going down, 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 except for the last column. But over 45, we have only one woman that was pregnant with pancreatitis. And after 40s, they were very, very few. So we have the problem of the hospital discharge records, because not every epidemiologist is safe about numbers in this kind of epidemiological studies. So we took 300 representative women in the 3 different groups: non-pregnant, pregnant, and postpartum, and look at the medical histories and comparing diagnosis of gallstones and acute pancreatitis according with the international terminology for the diagnosis, and look at the agreement between hospital discharge records and medical histories. And we obtained 92% of agreement for the diagnosis of acute pancreatitis and 88% agreement for the diagnosis of gallstones. So we concluded that our numbers are safe. So in our conclusion, we can use hospital discharge records in Sicily for epidemiological problem about pancreatitis and stones. Pancreatitis during pregnancy and in non-pregnancy is not different in the incidence. The incidence seems to be decreasing during the pregnancy and increase very much in the first semester, remain higher in the first 2 years. Acute pancreatitis increase with age in non-pregnancy and decrease in incidence in postpartum. About mortality, we have no mortality in the 34 patients with pancreatitis during pregnancy, and only one woman died of acute pancreatitis in the cohort of the postpartum series. And we have 29 in the 1500s of acute pancreatitis in the controls. So there is an increased mortality for pancreatitis during and after the pregnancy. If you look at the incidence in the last trimester, 14 for 100,000. In the first semester, 95 and more for 100,000 women years. I think that these numbers can suggest us that the gallbladder motility, that is the only change before delivery and after delivery, must have a role in the pathogenesis of acute pancreatitis in the women and maybe in all the condition. You need contractility of stones and pressure for the stones of the biliary sludge, move, injecting in the bile duct, pass through the OD sphincter, and start the process of the acute pancreatitis. Now there is the problem about the age, because young women, if have deliveries, are more risk to become with stones. Older new mothers have more chance to have spontaneous disappearance of stones. Acute pancreatitis is mainly in the young women, so there is something in the age that is different about the problem about pancreas and gallbladder. The physiology suggests us that after delivery in the older new mothers, there are more anovulatory cycle, late, longer amenorrhea period. This means less estrogen peak in the first months after delivery, and probably it means also more spontaneous, less lithogenic saturation index and more spontaneous disappearance of stones, less chance of acute pancreatitis. In youngest, on the contrary, after delivery, you have a prompt ovulation, no amenorrhea, higher estrogen with the peak of the ovulation, less chance of spontaneous disappearance, more chance of acute pancreatitis. What is the only physiological condition that can mimic what happened in the older new mothers? Breastfeeding. Breastfeeding give an ovulatory cycle, longer amenorrhea, less estrogen peak. So if the hypothesis is correct, looking at the breastfeeding role in the acute pancreatitis, we can find something. And what we did, so after 1 year, we published last year, in fact, this case control study on digestive science, like the first one on the cohort, in which we call acute pancreatitis after delivery, and we choose 4 control without acute pancreatitis that of women that had the delivery in the same month and in the same hospital of the case of acute pancreatitis. And of course, there is the recall bias that is a limit in the study of breastfeeding, because we don't know how much the mother can remember. The pregnancy and delivery were recent in the study. Most of the time between our inquiry was about 6 or 7 years. But for reducing the recall bias, we took 30 women with acute pancreatitis and 60 controls and asked the 2 pediatrician or general practitioner information about breastfeeding and look at the agreement between mothers and physicians notice about breastfeeding, and the results was very good, because breastfeeding, yes, no, 100 of agreement, and in how long have you breasted, you have only 3 mistakes, 1 pancreatitis, 2 controls, and all the 3 women had breastfed at least for 3 months, 2 or 3 months. We look at the results of the case control study. Here at the univariate analysis, you see that the history of oral contraception was related to the risk of acute pancreatitis. Amenorrhea at least 3 months was protective for the acute pancreatitis. Medical history of biliary disease was a predictor of pancreatitis. Breastfeeding at least 3 months was highly protective for the development of acute pancreatitis. And finally, smoking. Smoking was related to acute pancreatitis. At the multivariate, the independent factors were only 2. A history of biliary disorders that was associated with the presence of pancreatitis, and breastfeeding at least 3 months, because less doesn't work, as you can see. Breastfeeding 3 or more months has an important protective role in the development of acute pancreatitis. So our hypothesis has been confirmed for our epidemiological results. The conclusion is that if you have no biliary disease history, and if you breastfeed, have a low chance of having acute pancreatitis. And so you have to recommend, especially in the young new mothers, to breastfeed because they are at higher risk of acute pancreatitis. And here is the conclusion. We think that breastfeeding extends the protection with the long amenorrhea, less estrogen peak, more spontaneous disappearance of stones, less stones that are ejected in the common bile duct, and less pancreatitis. Thank you very much.